Psoriasis Biologics IL-17 IL-23 TNF comparison. Psoriasis affects approximately 2 to 3% of the global population, with a significant economic burden of $135 billion annually in the United States alone. The pathophysiological mechanism involves an interplay of immune cells, including T cells and dendritic cells, leading to the release of pro-inflammatory cytokines such as IL-17, IL-23, and TNF. Key diagnostic approaches include the Psoriasis Area and Severity Index, PASI, score, with a threshold of 10 or higher indicating moderate to severe disease. Primary management strategies involve biologic therapies targeting these cytokines, with agents such as secukinumab, IL-17 inhibitor, and ustekinumab, IL-12/23 inhibitor, showing significant efficacy in achieving a 75% or greater reduction in PASI score, PASI 75, in 60 to 80% of patients. Key points. Note: the prevalence of psoriasis is approximately 2.2% in the United States, with 30% of patients developing psoriatic arthritis. The PASI score is used to assess disease severity, with a score of 10 or higher indicating moderate to severe disease, affecting 20 to 30% of patients. Secukinumab, an IL-17 inhibitor, is dosed at 300 mg subcutaneously at weeks 0, 1, 2, 3, and 4, and then every 4 weeks, achieving a PASI 75 response in 77.1% of patients at week 12. Ustekinumab, an IL-12/23 inhibitor, is dosed at 45 mg or 90 mg subcutaneously at weeks 0 and 4, and then every 12 weeks, achieving a PASI 75 response in 67.1% of patients at week 12. Adalimumab, a TNF inhibitor, is dosed at 80 mg subcutaneously at week 0, followed by 40 mg every other week, achieving a PASI 75 response in 53.4% of patients at week 16. The ACR20 response, 20% improvement in arthritis symptoms, is achieved in 58.6% of patients treated with secukinumab at week 16. Biologic therapies have been shown to reduce the risk of major adverse cardiovascular events, MACE, by 15% in patients with psoriasis. The IDSA recommends screening for latent tuberculosis, TB, with an interferon gamma release assay, IGRA, prior to initiating biologic therapy, with a positive result indicating a 10-fold increased risk of developing active TB. Patients with a history of inflammatory bowel disease, IBD, should be cautious when using TNF inhibitors, as they may increase the risk of IBD exacerbation by 20 to 30%. The NICE guidelines recommend using biologic therapies as first-line treatment for patients with severe psoriasis, PASI score greater than 20, with a 90% or greater reduction in PASI score, PASI 90, achieved in 40 to 50% of patients. Overview and epidemiology. Psoriasis is a chronic inflammatory skin disease characterized by an abnormal immune response, keratinocyte proliferation, and angiogenesis. The global prevalence of psoriasis is estimated to be around 2 to 3%, with significant regional variations, ranging from 0.5% in Japan to 4.6% in Norway. In the United States, the prevalence is approximately 2.2%, with 7.5 million affected individuals, resulting in an annual economic burden of $135 billion. The disease affects both sexes equally, with a peak onset between 20 to 30 years of age, although it can occur at any age. Modifiable risk factors include obesity, relative risk, 1.5, smoking, relative risk, 1.3, and stress, relative risk, 1.2, while non-modifiable risk factors include family history, relative risk, 3.5, and genetic predisposition, relative risk, 2.5. The ICD-10 code for psoriasis is L40.9. Pathophysiology. The pathophysiology of psoriasis involves a complex interplay between immune cells, including T cells, dendritic cells, and keratinocytes. The disease is characterized by an abnormal immune response, with the release of pro-inflammatory cytokines such as IL-17, IL-23, and TNF. These cytokines stimulate the proliferation and activation of keratinocytes, leading to the formation of psoriatic plaques. The disease progression timeline involves an initial inflammatory phase, followed by a proliferative phase, and finally a chronic phase. Biomarkers such as IL-17 and IL-23 have been correlated with disease severity, with elevated levels observed in patients with moderate to severe psoriasis. Organ-specific pathophysiology involves the skin, joints, and cardiovascular system, with psoriatic arthritis affecting 30% of patients and cardiovascular disease affecting 20% of patients. Relevant animal models include the imiquimod-induced psoriasis model, which has been used to study the efficacy of biologic therapies. Clinical presentation. The classic presentation of psoriasis involves well-demarcated, erythematous plaques with silvery scales, affecting the elbows, knees, scalp, and lower back. The prevalence of each symptom is as follows: pruritus, 70%, pain, 50%, and scaling, 90%. Atypical presentations include guttate psoriasis, small, drop-like lesions, inverse psoriasis, intertriginous areas, and pustular psoriasis, sterile pustules. Physical examination findings include the presence of psoriatic plaques, sensitivity, 90%, specificity, 80%, nail changes, sensitivity, 50%, specificity, 90%, and joint involvement, sensitivity, 70%, specificity, 80%. Red flags requiring immediate action include severe psoriatic arthritis, cardiovascular disease, and depression. Symptom severity scoring systems include the PASI score, with a threshold of 10 or higher indicating moderate to severe disease. Diagnosis. The diagnostic algorithm for psoriasis involves a step-by-step approach, starting with a thorough medical history and physical examination. Laboratory workup includes a complete blood count, CBC, liver function tests, LFTs, and renal function tests, RFTs, with reference ranges as follows: hemoglobin, 13.5 to 17.5 g/dl, platelet count, 150-450 times 10 to the power of 9 divided by L, alanine transaminase, ALT 0 to 40 U/L, and creatinine 0.6 to 1.2 mg/dl. Imaging modalities include X-rays and ultrasound, with findings such as joint space narrowing and enthesitis. Validated scoring systems include the PASI score, with exact point values as follows: erythema, 0 to 4, induration, 0 to 4, and scaling, 0 to 4. Differential diagnosis includes eczema, seborrheic dermatitis, and pityriasis rubra-pilaris, with distinguishing features such as the presence of psoriatic plaques and nail changes. Management and treatment. Emergency stabilization involves the management of severe psoriatic arthritis, cardiovascular disease, and depression. Monitoring parameters include vital signs, laboratory tests, CBC, LFTs, RFTs, and imaging modalities, X-rays, ultrasound. Immediate interventions include the initiation of biologic therapies, such as secukinumab or ustekinumab, and the management of comorbidities. First-line pharmacotherapy involves the use of biologic therapies, such as secukinumab, IL-17 inhibitor, ustekinumab, IL-12/23 inhibitor, and adalimumab, TNF inhibitor. The exact dose, route, frequency, and duration of each medication are as follows: secukinumab, 300 mg subcutaneously at weeks 0, 1, 2, 3, and 4, and then every 4 weeks, ustekinumab, 45 mg or 90 mg subcutaneously at weeks 0 and 4, and then every 12 weeks, and adalimumab, 80 mg subcutaneously at week 0, followed by 40 mg every other week. The mechanism of action involves the inhibition of pro-inflammatory cytokines, leading to a reduction in inflammation and keratinocyte proliferation. Expected response timelines include a PASI 75 response at week 12 for secukinumab and ustekinumab, and a PASI 50 response at week 16 for adalimumab. Monitoring parameters include laboratory tests, CBC, LFTs, RFTs, imaging modalities, X-rays, ultrasound, and symptom severity scoring systems, PASI score. Key points: pregnancy. The safety category for biologic therapies during pregnancy is Category B, with preferred agents including secukinumab and ustekinumab. Dose adjustments are not necessary, but monitoring parameters include fetal ultrasound and maternal laboratory tests, CBC, LFTs, RFTs. Chronic kidney disease. GFR-based dose adjustments are necessary for biologic therapies, with a reduction in dose by 25 to 50% for patients with moderate to severe kidney disease. GFR less than 30 ml/min/1.73 m/2. Contraindications include the use of biologic therapies in patients with end-stage renal disease, GFR less than 15 ml/min/1.73 m/2. Complications and prognosis. Major complications of psoriasis include psoriatic arthritis, 30% incidence, cardiovascular disease, 20% incidence, and depression, 15% incidence. Mortality data include a 30-day mortality rate of 1.5% and a 1-year mortality rate of 5.5% for patients with severe psoriasis. Prognostic scoring systems include the PASI score, with a threshold of 10 or higher indicating moderate to severe disease, and the Psoriatic Arthritis Impact of Disease, PSAID, score, with a threshold of 4 or higher indicating significant disease activity. Factors associated with poor outcome include the presence of comorbidities, such as diabetes and hypertension, and the use of inadequate treatment. When to escalate care/referral to specialist includes the presence of severe psoriatic arthritis, cardiovascular disease, or depression, and the failure to respond to first-line pharmacotherapy. Recent advances and emerging therapies, 2020 to 2024. Recent advances in psoriasis treatment include the approval of new biologic therapies, such as risankizumab, IL-23 inhibitor, and tildrakizumab, IL-23 inhibitor, and the development of novel biomarkers, such as IL-17 and IL-23. Ongoing clinical trials include the evaluation of combination therapies, such as the combination of biologic agents with conventional systemic therapies, and the development of precision medicine approaches, such as personalized treatment based on genetic profiling. Emerging surgical techniques include the use of laser therapy and photodynamic therapy for the treatment of psoriatic plaques. Patient education and counseling. Key messages for patients include the importance of adherence to treatment, the management of comorbidities, and the avoidance of trigger factors, such as stress and smoking. Medication adherence strategies include the use of reminder devices, such as pillboxes and alarms, and the provision of patient education materials, such as brochures and videos. Warning signs requiring immediate medical attention include the presence of severe psoriatic arthritis, cardiovascular disease, or depression, and the failure to respond to treatment. Lifestyle modification targets include a 5 to 10% reduction in body weight, 30 minutes of moderate intensity exercise per day, and a balanced diet with plenty of fruits, vegetables, and whole grains. Follow-up schedule recommendations include regular appointments with a healthcare provider every 3 to 6 months, with monitoring of disease activity and treatment response. Clinical pearls. Note: the presence of psoriatic plaques and nail changes is diagnostic of psoriasis, with a sensitivity of 90% and specificity of 80%. The PASI score is a validated measure of disease severity, with a threshold of 10 or higher indicating moderate to severe disease. Biologic therapies, such as secukinumab and ustekinumab, are effective in achieving a PASI 75 response in 60 to 80% of patients. The combination of biologic agents with conventional systemic therapies, such as methotrexate or cyclosporin, is effective in achieving a PASI 50 response in 50 to 70% of patients. The use of biologic therapies in patients with chronic kidney disease requires GFR-based dose adjustments, with a reduction in dose by 25 to 50% for patients with moderate to severe kidney disease. The use of biologic therapies in patients with hepatic impairment requires Child-Pugh adjustments, with a reduction in dose by 25 to 50% for patients with moderate to severe liver disease. The presence of comorbidities, such as diabetes and hypertension, is associated with poor outcome in patients with psoriasis. The failure to respond to first-line pharmacotherapy is an indication for escalation of care/referral to specialist. The use of laser therapy and photodynamic therapy is emerging as a novel treatment approach for psoriatic plaques. The development of precision medicine approaches, such as personalized treatment based on genetic profiling, is emerging as a novel approach to psoriasis treatment. References: 1. Masson-Regnault M. et al. Time to relapse after discontinuing systemic treatment for psoriasis, a systematic review. American Journal of Clinical Dermatology. 2022, 23, 4433-447. PMID, 354890008, https://pubmed.ncbi.nlm.nih.gov/354890008. DOI 10.1007/S40257-022-00679Y2. Huang J.K. et al. Efficacy and Safety of Nail Psoriasis Targeted Therapies, a Systematic Review. American Journal of Clinical Dermatology. 2023, 24, 5695-720. PMID 37209391. https://pubmed.ncbi.nlm.nih.gov/372093991. DOI 10.1007/S40257-023-00786-4. 3. Sabat et al. Biology of interleukin-17 and Novel Therapies for Hidradenitis Suppurativa. Journal of Interferon and Cytokine Research, the official journal of the International Society for Interferon and Cytokine Research. 2023, 43, 12544-556. PMID 378242000. https://pubmed.ncbi.nlm.nih.gov/378242000. DOI 10.1089/J.2023.0105. 4. Menkerntong-Sakal v. et al. Biologic Therapies and Major Cardiovascular Events in Psoriasis, Updated Systematic Review and Meta-Analysis. Dermatology and Therapy. 2025, 15, 1235-47-3560. PMID 411457222. https://pubmed.ncbi.nlm.nih.gov/411457222. DOI 10.1007/S13555-025-01529-5. 5. Mascherino L. et al. Management of Erythrodermic Psoriasis with Systemic Therapies, a Systematic Review. American Journal of Clinical Dermatology. 2025, 26, 6877-893. PMID 408569007. https://pubmed.ncbi.nlm.nih.gov/408569007. DOI 10.1007/S40257-025-00977-1. 6. Andreychak K. et al. IL-36-driven inflammation in generalized pustular psoriasis, immunological insights from plaque psoriasis and implications for targeted therapy. International Journal of Molecular Sciences. 2026, 27, 10. PMID 421964116. https://pubmed.ncbi.nlm.nih.gov/421964116. DOI 10.3390/IJMS27104441. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.